नमस्कार। आज का केस बहुत ही इंटरेस्टिंग क्लिनिकल केस है एंड वी विल ट्राई टू डिस्कस। ये मिक्सचर ऑफ many things are there. So the question is, a 58-year-old man with type 2 diabetes and hypertension presents to emergency department with acute right upper quadrant abdominal pain and fever for 6 hours. So seems to be it is because of some infection. Examination reveals temperature of 38.1 degrees C, pulse of 96 and blood pressure of 146 by 84. Murphy's sign is positive, which means gallbladder is inflamed or some inflammation is there. ECG at admission is normal, which rules out any cardiac cause of the pain. Abdominal ultrasound confirms acute calculus cholecystitis. So with this, in the emergency department, patient is administered first dose of antibiotic and it is intravenous ceftriaxone. Immediately after giving ceftriaxone, within minutes, patient develops sudden breathlessness, generalized flushing, hypotension with blood pressure of 78 by 46 and chest tightness, which means that patient has developed allergic reaction, most probably an anaphylaxis. ECG is done and ECG shows ST segment elevation in inferior and anterior leads with ventricular arrhythmias. So that is supportive that acute ischemic attack has happened, acute coronary syndrome has happened, myocardial infarction has happened, and this is supported by troponin level. So high sensitivity HST troponin is elevated and it is 0.28 nanogram per ml. So this patient is immediately treated with intramuscular epinephrine, intravenous hydrocortisone, antihistamines and fluids. With this treatment, symptoms resolve rapidly. Repeat ECG normalizes within 24 hours. Coronary CT angiogram shows no significant coronary artery disease or occlusion. So the question is, which of the following is most appropriate diagnosis? A. Acute plaque rupture causing ST elevation myocardial infarction. B. Takotsubo cardiomyopathy triggered by infection. C. Type 1 Kounis syndrome due to antibiotic induced allergic reaction. D. Type 2 myocardial infarction due to sepsis induced hypotension. And C. Acute viral myocarditis. Now let us understand this case appropriately. Now this case is Kounis syndrome. This is because Kounis syndrome has classical feature of allergic myocardial ischemia, and here in this patient we have a clear allergic trigger. Symptoms began within minutes of IV ceftriaxone and patient had developed flushing, hypotension and breathlessness which suggest anaphylaxis. The second part is acute coronary involvement during allergy. So that is evident from ST segment elevation in inferior and anterior leads, ventricular arrhythmias and elevated troponin. The other and third important part of Kounis syndrome is its a rapid resolution. Here in this patient, symptoms resolved after epinephrine, ECG normalized in 24 hours, and coronary CT angiogram did not show any obstruction in coronary artery disease. Thus, this strongly supports allergic coronary vasospasm and not plaque rupture. So let us once again understand what is Kounis syndrome. Kounis syndrome is acute coronary syndrome triggered by mast cell activation during an allergic reaction. The pathophysiology is allergen, where it is ceftriaxone here, leads to mast cell activation, releasing histamine, leukotrienes, and tryptase, which leads to coronary vasospasm, which may have additional plaque destabilization if there is pre-existing coronary artery disease. That leads to ST segment elevation and troponin rise. There are three types of Kounis syndrome. Type 1 have normal coronaries, and it is basically because of coronary vasospasm in response to allergy. Type 2, patient has got pre-existing coronary artery disease and plaque rupture occurs in response to allergic vasospasm. And type 3 is stent thrombosis, in which because of allergen, allergic thrombosis occurs. This patient has got normal coronary CT with no prior history of coronary artery disease and transient ECG changes, which is supportive of type 1 Kounis syndrome. Now let us evaluate other options. Option number A, acute plaque rupture STEMI. Now this would show persistent ECG change and obstructive lesion on CT angiography, which is not here. Takotsubo cardiomyopathy typically shows apical ballooning on echocardiography. There is often no immediate allergic onset, and ECG changes do not resolve this rapidly. So it is not Takotsubo cardiomyopathy also. Type 2 myocardial infarction, that is mainly because of supply-demand mismatch. It occurs in prolonged hypotension or sepsis, does not cause dramatic ST changes which occurred in this patient, and does not cause arrhythmia. Option E, acute viral myocarditis, is also wrong because it has got subacute presentation and it is not triggered immediately after antibiotic, and there is no rapid normalization. So the answer is C, type 1 Kounis syndrome due to antibiotic induced allergic reaction. Dear friends, what are the pearls from today's topic? Sudden allergic reaction with ST segment elevation and normal coronaries are suggestive of Kounis syndrome until proven otherwise. And these allergic reactions especially occur after antibiotics like ceftriaxone and penicillin, NSAID, contrast media, or B stinge.